Hi, I'm Jim Amos, and I'll be giving a short Pecha Kucha talk about CL psychiatry. The fireman's helmet indicates that I run all over the hospital when I'm paged by doctors who want me to help put out fires, so to speak. And the thing I'm holding in my hand is a camp stool because I think it's more respectful to sit with patients. I'm going to be talking about the what, who, why, and how of CL psychiatry. It's important to know what it is, what kind of medical professional does this kind of work, why we need CL psychiatry, and especially how we do it. CL psychiatry is a subspecialty at the interface of medicine and psychiatry and was called psychosomatic medicine until October of 2017. The term psychosomatic tends to be linked with the term imaginary, and most CL psychiatrists don't think it's an appropriate term for our specialty. As far as who does CL psychiatry, the groups listed on this slide are associated with the specialty, and the flagship organization is the Academy of Consultation Liaison Psychiatry. Why do we need CL psychiatrists? 10% of patients use 63% of the healthcare dollar. They are often complex with comorbid chronic medical and psychiatric illness, and they tend to be high utilizers of our healthcare system. CL psychiatrists are specialists in treating many of these patients. There are many studies that show there are increased costs due to mental disorders in general hospitals. There are over 26 international and American studies showing that psychiatric comorbidity leads to increased length of stay, costs, and rehospitalization rates. Why do we need CL psychiatrists? Well, they have medical expertise that tends to be beyond the scope of general psychiatrists. They're familiar with medical surgical cultures, and they're comfortable dealing with patients who have comorbid severe mental and psychiatric illness. How to staff a CL psychiatry service in a general hospital depends heavily on having enough manpower. A CL service generally requires about one clinical full-time equivalent per 100 beds. And so if you have a 700-bed hospital, then you should have about a half a dozen CL psychiatrists. There are a couple of CL psychiatry models. I call them gunslinger and chessmaster. The gunslinger is reactive, and that's what I've done. Proactive case finding, I tend not to do. My liaison is done on the run. Chessmaster or integrated CL psychiatrists do proactive case finding and liaison formally. There are advantages to an integrated CL service. Proactive early screening has been studied, and it can increase detection of mental disorders, and the timing of consult requests can be earlier in the course, and earlier detection can reduce length of stay. You can compare integrated versus what I call hit and run CL programs. Collaboration in an integrated system occurs in a specified multidisciplinary team, while in hit and run systems like the one I've been in, one person runs all over the hospital and collaborates less formally. How to do a psychiatric consultation is covered in the book Psychosomatic Medicine: An Introduction to CL Psychiatry, edited by me and a colleague. The consult process in detail involves reviewing the record and test results, introducing yourself, interviewing the patient and any visitors, sitting down, which helps build rapport, writing a note without psychobabble, and following up as needed. Sitting with the patient has been studied in terms of how it influences the doctor-patient relationship. Camp stools are fine for this, but when they break, it can be a little bit embarrassing, although also uproariously funny. The core competencies are as important for CL psychiatry as they are for the rest of medicine. They include patient care, system-based practice, practice-based learning, medical knowledge, professionalism, and interpersonal and communication skills. And without interpersonal and communication skills, the rest of this pizza is pretty flat. The next several slides are about assessing, preventing, and managing delirium. Delirium is an important syndrome that's potentially reversible, but it's an acute brain injury. One way to screen for it is with the Confusion Assessment Method, or the CAM. Dealing with delirium involves anticipating it, and we made the delirium order set for our physicians in order to help them anticipate, prevent, and manage it. We also made screensavers out of the slides that you see here. It's impossible to overemphasize how dangerous delirium is, especially to the elderly. Up to 42% of inpatients will experience delirium, and the clock draw task is a part of the mini-cog, which we use to screen for delirium. Up to 2/3 of cases of delirium are either not diagnosed or misdiagnosed, often as a primary psychiatric illness because delirium mimics those. The pocket cards you see here I made up for the trainees so as to make it easier for them to screen for delirium. They include the CAM and the mini-cog. The last slide just emphasizes how important practice-based learning and improvement is. And on the CL Psychiatry service here, we do it with the Clinical Problems in Consultation Psychiatry case conference. It's one of the most important and popular educational formats.